Hello, bonjour, and welcome to this public webinar offered as part of Healthcare Excellence Canada's program, Sparking Change in the Appropriate Use of Antipsychotics. The program aims to support long-term care homes across Canada to improve the appropriate use of antipsychotics through person-centered care. Registration is still open, so if you're a long-term care home in Canada, you're welcome to join us for further quality improvement supports, coaching, and financial award opportunities. My name is Nicole Pollock. I'm a senior program lead on the Health Innovation Programs team at Healthcare Excellence Canada. My pronouns are she, her, and I'll be your host for today's webinar. We are pleased to offer French simultaneous interpretation. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. We invite you to share your questions and comments at any point during the webinar in English or French by typing into the chat box. We will address as many questions as possible during the Q&A session near the end of the webinar. If you need support at any time, please reach out to our tech support using the chat feature. This session is being recorded, and the recording will be made available in the coming days, both through our YouTube channel, which will be linked in the chat, and it'll also be posted on our ATC website within a few business days. I want to start by acknowledging that I'm joining you from Anishinaabe, which is the traditional territories of the Anishinaabe people, colonially known as Ottawa, where the heat wave has finally broken, thankfully. Healthcare Excellence Canada is also located in Ottawa, with staff all across the country. HEC honors the traditional territories upon which our staff and partners live and supports our journey towards truth and reconciliation. I invite you to share who you are and where you're joining from in the chat box. For those new to us, HEC is a not-for-profit organization funded by Health Canada. We collaborate with diverse people and organizations across the country to spread innovations, build capability, and catalyze policy changes that improve healthcare safety and quality. I'd like to acknowledge and thank our supporting organizations who are helping to promote the program with ongoing recruitment of homes to participate and the review of award submissions. So speaking of awards, we want to celebrate the latest winners of our Person-Centered Care Award. Each of these long-term care homes won $5,000 for their work on improving person-centered care and non-pharmacological approaches within their homes. So congratulations to all of these winners. If you'd like to join the Sparking Change in AUA program for the chance to win financial awards like this one, you can still register through the QR code on this screen or through our HEC website. So the objectives of today's webinar are to review the Canadian Institute for Health Information, or CIHI's, potentially inappropriate use of antipsychotics quality indicator. We'll discuss the indicator inclusion and exclusion criteria and coding. We'll explore how data monitoring drives quality improvement, and of course, answer any questions you may have. I'm pleased to welcome our speakers for today. Jacqueline Smith is the team lead for clinical standards and training for specialized care standards and engagement at the Canadian Institute for Health Information. Jacqueline leads strategic and operational activities related to the development, enhancements, promotion, training, education, and implementation in the use of specialized care data standards and standardized assessments across Canada. Her experience in healthcare project management, health policy and procedures, information management, and information technology systems and standards has enabled her in managing system change and integration. And Patricia Hanna is a clinical specialist in specialized care standards and engagement at CIHI. Patricia supports the use and implementation of the Inter-I long-term care assessments in Canada by providing education on Inter-I standards and use of clinical and organizational outputs. Her background in nursing and health information management in clinical oncology trials has allowed her to support clinicians in the completion of assessments and use of data. And last but not least, Cynthia Sinclair is a coach and advisor to HEC for this program. She's a retired registered nurse with over 35 years of experience. Cynthia has served in a variety of roles with the Winnipeg Regional Health Authority, as well as becoming a director of care for a large Winnipeg long-term care home and CEO of a long-term care home in England. Cynthia is a graduate of HEC's Extra Fellowship Program, where her intervention project set the foundation for these future AUA collaboratives across the country. Using her experience and expertise, Cynthia has worked tirelessly with many long-term care homes and organizations to create and sustain person-centered care environments that improve the lives of residents. So once again, feel free to drop any questions into the chat box throughout the presentation. And without further ado, I'll turn it over first to Jacqueline.
Thank you, Nicole. So thank you, and we appreciate the opportunity to present today with our continued collaboration with Health Excellence Canada. CIHI works towards better health for all Canadians, and we're mindful that we live on the traditional territories of and work with First Nations, Inuit, and Métis in a respectful way. Pat and I are both joining you today from Ottawa and Kingston, Ontario, and we acknowledge that we are on the traditional and ancestral territories of Anishinaabe, Haudenosaunee, Huron-Wendat, and Métis people. The intent of the presentation today is to bring awareness and understanding about this particular indicator, to clarify its purpose, provide more detail on how it's calculated, and address some misconceptions. Will also examine how you can use CIHI's new secure reports to trend this QI as part of your quality improvement initiative. Next slide, please. So for the agenda, we'll begin with an overview of the long-term care quality indicators in general. We'll then go over the basic calculation of the potentially inappropriate use of antipsychotics quality indicator. We'll take a closer look at the items of the LTC assessment used in the calculation. And then in particular, we'll focus on item definitions and some scenarios for you to gain a better understanding of the exclusions that are applied in the calculation. We'll wrap up on how you can use the QI as part of a quality improvement initiative and how you can use CIHI reports to trend results, and finish with some key messages. Next slide, please. So just a few words about CIHI. Working alongside health jurisdictions and partners, CIHI works to accelerate the growth of the country's health data ecosystem to drive more innovation and evidence-informed decisions. The goal is to give Canadians the highest quality of care and the best health outcomes. In Canada, CIHI is trusted with harnessing the full potential of pan-Canadian health information. It's our job to ensure health data is connected, accessible, comprehensive, timely, relevant, and contextualized. We know that data can drive change. CIHI's role to orchestrate the conditions orchestrate the conditions to achieve it. Together, we deliver better data, better decisions for healthier Canadians. As part of our new transformation agenda, CIHI is aligned with the principles of Pan-Canadian Health Data Charter and committed to fully leverage Canada's health data assets, so people, technology, and ecosystems, to create real change and to ensure relevancy in everything we do to meet the needs of people and organizations who depend on CIHI, and to provide a system view for change leading to actionable insights. Next slide, please. So CIHI and INTERI work closely together. INTERI is a collaborative network of researchers and practitioners in over 35 countries committed to improving care for persons who are disabled or medically complex. Their network strives to promote evidence-informed clinical practice and policy decision-making. INTERI develops the clinical standards and the associated outputs, which are measurements that are derived from the completed assessments. They work with us at CIHI to refine or Canadianize the INTERI standards. At CIHI, we serve as the custodian of the INTERI standards for Canada and a repository of INTERI data that comes in from the completed assessments. We produce specifications for a number of the INTERI standards, which are used by vendors across the country. And we provide data to INTERI for their research and analysis. Next slide, please. And now I will hand things over to Pat to start with a review of the INTERI QIs in general.
Okay, thank you, Jacqueline. So we're going to start with a review of the INTERI QIs. Next slide, please. So LTC quality indicators, first of all, were developed by INTERI. The methodology behind those indicators do lie with INTERI. CIHI supports the use of these quality indicators by providing information and reporting. So QIs are pointers that indicate potential areas in care that need further review and investigation, and they're meant to improve care. Care providers and governments use quality indicators to monitor, improve the quality of care within and across organizations. There are prevalence and incident indicators, and they're expressed in percentages. So QI will measure across key domains such as safety, health status, physical and mental function. And there are a total of 34 quality indicators for the LTCF assessment and 35 in the RIMDS. Next slide, please. So thinking of the quality indicator in general, do higher percentages in quality indicators reflect inadequate or poor care? Next. So the answer to this is no. There are circumstances that can be out of a long-term care facility or home's control. We'll always have some individuals with more complex health conditions that make them more at risk of falls and worsening conditions. Indicators are not meant to be punitive or to flag poor care. They are meant to improve care. So the rate is not expected to be zero. And there are also incident indicators that reflect improvement. Next slide, please. So we'll take a closer look at the potentially inappropriate use of antipsychotic QI. Next slide. So first, here are some facts about antipsychotic use in long-term care. People may arrive from hospital or community setting already on an antipsychotic medication. Other conditions that are not excluded from the calculation may warrant an antipsychotic. So this quality indicator, the rate is not expected to be zero. And sometimes benefits of the antipsychotics may outweigh the side effects. Next slide. So this is how the indicator is described on our indicator library at CIHI on our public website. So it is labeled the potentially inappropriate use of antipsychotic in long-term care. The QI code is DRG01, and it's described as how many long-term care residents are taking antipsychotic drugs without a diagnosis of psychosis. The interpretation, lower is better. It means that a lower percentage of long-term care residents receiving antipsychotic medication without a diagnosis of psychosis. Next slide. So why is this a quality indicator? So there's risks associated with using antipsychotics with older adults, especially with people living with dementia, which makes up a significant proportion of the long-term care population. So according to the Alzheimer's Society of Canada's website, it should only be used by people living with dementia if their behavior problems do not improve with non-drug approaches, the person is threatening to harm themselves or others, and they should never be used for more than 6 to 12 weeks. Older adults as well are most likely to be prescribed multiple medications, increasing the likelihood of negative drug interactions. And older adults with comorbidities such as diabetes and heart disease, there's also a risk. And finally, side effects of the medication can also increase the risks of falls. Next slide, please. So there's been a lot of media and academic interest on the topic of antipsychotic use in long-term care for several years, and it continues to be a hot topic. In particular, there was concern in the use of it as chemical restraint during the COVID-19 pandemic. So patients who wandered as one of their psychological and behavioral symptoms of dementia were often unable to follow or recall infection prevention and control precautions, putting them at risk of contracting or spreading COVID-19. Next slide. So what classifies as an antipsychotic? So first, it's based on the World Organization's Anatomic Therapeutic Classification, or ATC. It includes medications listed under the ATC classification of N05A. And assessors need to review the clinical records for documentations that an antipsychotic was received by the person, capture antipsychotic medication regardless of their intended use. And for people newly admitted, it's important to review transition admission documents for indication of antipsychotic use. And also be aware of long-acting antipsychotic medications that are given less than weekly. Next slide, please. So the indicator is calculated by dividing the number of residents who received antipsychotic medications by the number of all residents with valid assessments. Indicator-specific exclusions are then applied, which are select items that are coded as present on the assessment within the reporting period. and we will take a look at them more closely. Next slide. So what do we mean by valid assessment? Residents with valid assessments represent target assessments that are the latest assessment in the reporting quarter. It was an assessment completed more than 92 days after that person's admission. And the assessment was not the admission assessment or a first assessment of that person that's completely shortly after their admission. Next slide. So this depicts the specific coding of items in both RIMDS 2.0 and Inter-I LTCF associated to the exclusions that we are going to examine more closely. Next slide. So the following is a simple example. So out of all assessments in the reporting quarter, there are 80 residents with valid assessments with exclusions that are applied, which is the denominator. Out of those 80 resident assessments, 20 assessments were coded as having received an antipsychotic, which is the numerator. 20 divided by 80 multiplied by 100 would give us a rate of 25% for this quality indicator within the reporting period. Next slide. So here are the items of the assessment. If they are coded as present, will exclude a resident assessment as part of the denominator. In terms of diagnoses, there are two. There's schizophrenia and Huntington's disease. Items under section J, if present, would be delusions and hallucination, or someone having an end-stage disease with 6 or fewer months to live. And finally, people who are identified as being in a hospice or palliative care program at the time of assessment. Next slide. So there is a difference in the capture of exclusions between RIMDS 2.0 and Inter-I LTCF, and this is mostly based on the difference in coding options that are available. So in the case of Huntington's disease, the disease is an actual item in the RIMDS 2.0 assessment, and it's simply coded as yes or no. As for the Inter-I LTCF, an ICD-10 code requires to be captured in section I2 of the assessment to identify it. Now, the coding options are more expansive in the LTCF compared to RIMDS 2.0. So the presence of a condition or health problem in section J of the RIMDS 2.0 assessment is only coded if it's present in the last 7 days. For the LTCF, there is an expansion of coding options that include the presence of a condition or health problem as being present but not exhibited in the last 3 days. So if coded as such, it would also be used to exclude, for example, hallucinations, delusions, end-stage disease, 6 or fewer months to live. Next slide. So let's look at this depiction of residents at our fictitious West Hill home to see how the QI is calculated. Residents who had an admission or first assessment completed in the reporting period are removed, as well as resident assessments with one or more of the coded items mentioned as indicator-specific exclusion. Next. What are left are 9 valid eligible assessments. Next. Only 3, the burgundy ones, will be excluded and counted in the quality indicator because the antipsychotic item is coding as being received and there are no exclusions coded on those assessments. Next. And next slide. So knowing about what a valid assessment represents, let's look at this scenario. So Mr. M is a new admission to West Hill, transferred from the local hospital. During his stay, he was started on an antipsychotic. His medication, including the antipsychotic, was continued according to the admission orders upon his transfer. His first assessment was completed within 7 days. So will Mr. A's assessment be included or excluded from the calculation? Next. Here it would be excluded. So the first or an admission assessment is not used in the calculations. Next slide. Let's now look at how antipsychotic use is captured in the assessment. Next slide. So in the intra-LTCF, section N7 will capture 4 different classes of psychotropic medications. Antipsychotic use, if applicable to the resident, is captured under N7A. And it's simply a yes or no if received in the last 7 days. If a long-acting medication of an antipsychotic was administered outside the 7-day observation period, it is also counted as yes. Next slide. So in the RIMDS 2.0, section 04 will capture 6 classes of drugs. Antipsychotic use is captured under 04A, and it's the number of days received in the last 7 days that are recorded. If a long-acting medication was administered outside that 7-day observation period, it is recorded as 1. Next slide. So to support assessors in identifying and determining drugs within those classes, CIHI developed a reference guide intended to help assessors identify drugs according to their classification. So this reference guide is reviewed and updated on an annual basis as new drugs may be developed and marketed, or some may become no longer currently in use. And here in particular, we can see a snapshot of the section of antipsychotics. So in this part of the assessment, we're capturing the use of drugs according to their classification and not their use. So an example that we have here is Librium. It's used as a mood stabilizer. It is still considered an antipsychotic based on its classification and not its use as a mood stabilizer. Next slide. So the following is an example of an antipsychotic use scenario. So Mr. B has been receiving a long-acting injection of paliperidone every 3 months to help treat symptoms associated to schizophrenia. It was administered 2 weeks ago. So would this be captured under N7A? Next. So the answer is yes. So long-acting medications that are received outside that 7-day observation would be counted and captured in this case. So medications that have a continued therapeutic effect are counted and captured in this case. Next slide. Now we're going to take a closer look at the exclusion items used in the calculation. Next slide. So there's only 2 diagnoses used as exclusions in this indicator: schizophrenia and Huntington's disease. So this is the intent and process of coding diagnoses as present in the assessment. Only diseases that are current at the time of assessments are to be captured. And when we speak of schizophrenia, there's only certain subtypes that are included. Next slide. So as mentioned earlier in the LTCF assessment, if we have a resident with a diagnosis of Huntington's, an ICD-10 code is required to be captured to identify that person's condition. So again, CIHI has developed a job aid to flag certain diagnoses that are used in output calculations that assessors should be aware of, and if it is applicable to the resident. So Huntington is one of those diagnoses. Next slide. So again, the only 2 diagnoses that are used as an exclusion are schizophrenia and Huntington's. So schizophrenia does include subtypes such as paranoid, disorganized, catatonic, undifferentiated, residual. And there are no other diagnoses that could be captured as ICD-10 codes that could be used. These are the only 2 diagnoses that are applied to this indicator. Now, there are other health conditions in section J of the assessments that are used as exclusions. So we're going to take a closer look at their definition and how to interpret each of them. Next slide. So the delusion item is used as an exclusion, but it's important to understand its definition. So the key word here is fixed, and it's defined as false belief not shared by others that the resident holds, even when there is obvious proof or evidence to the contrary. So let's look at a couple of scenarios. Next slide. So here we have Mr. G. He's convinced on a daily basis that staff are deliberately tampering with his food, watching him struggle and making jokes. He refused to eat at meals despite his wife and others telling him that this is not happening. Next. So this represents a fixed belief. It occurs each mealtime and we cannot convince him otherwise. Let's look at another scenario. Next slide. So Mrs. C carries a baby doll as part of therapy throughout the day for comfort. She gets upset when she must return it to the therapy room, but doesn't talk or dwell about it afterwards. Would we code this as delusions? Next. No. Here, there's no indication that she's fixated on the doll or believe that it is real, and she doesn't talk about it after it is returned. Now, delusions that are result of an iatrogenic process cannot be coded as a delusion because someone has introduced the doll. So this is what we would consider a misidentification. Next slide. Hallucinations are also used as an exclusion criteria. So it is defined as false perceptions that occur in the absence of any real stimuli. A hallucination can be auditory, visual, tactile, olfactory, or gustatory. Next slide. So here we have Mrs. K always sees little people standing behind the plants in her room in the afternoon, and she asks, what are they doing back there? Would we code hallucinations? Next. Yes, she always sees little people. There is no one behind the plants. So this would meet the definition of a visual hallucination. And she sees this on a continual basis every afternoon. Next slide. Here we have Mrs. D hears someone knocking outside the window of her room every evening. The noise is coming from the corridor when the staff are doing their rounds. Would we code this as a hallucination? Next. No, this represents a misinterpretation of where the noise is coming from. So this is not an auditory hallucination. Next slide. So end-stage disease, 6 or fewer months to live, is another exclusion for this quality indicator. It's very important to understand the intent of the definition of this item. So part of it means that the person has end-stage disease with approximately 6 or fewer months to live. And this judgment should be substantially that lead to a well-documented disease diagnosis. And the key word here is deteriorating clinical course. Note that the items under J6 and J5 of the assessment are about the stability of conditions. So the intent is to determine if the resident's disease or health conditions that are present are acute, unstable, or deteriorating. So not all end-stage disease scenario apply in the context of this item. So a person may be living with a disease labeled end-stage on its own that is stable. This would not be captured under this item. Also, the palliative symptom scale is also not recommended to be used to determine this item in the context of the assessment, which was confirmed by Interi. So let's take a closer look at a couple of scenarios. So next slide. So here we have Mrs. M, who has advanced interstitial pulmonary fibrosis. In the last 3 days, she's been decompensating. She's unable to get out of bed or eat. She's struggling to breathe. Palliative orders are in effect. Morphine is administered regularly to keep her comfortable. Would we capture this as end-stage disease, 6 or fewer months to live? Next. So this would meet the definition. Mrs. M is unstable and is exhibiting a deteriorating clinical course. Next slide. Here we have Mr. J, who's been living with end-stage Lewy body dementia for some time. His routine care has remained the same for months and he is stable. Would we code end-stage disease, 6 or fewer months to live? Next. No. Here it's very clear his care has not changed. There is no indication that he is unstable and deteriorating. So this is not the case here. So finally, the hospice and palliative care. item is also used as an exclusion. So although the definition is slightly expanded in the LTCF, this item is intended to identify a person in a formal program specialized in palliation of symptoms, usually related to end of life. Next slide. So the following is an example. Mrs. N has stage 4 lung cancer. Chemotherapy and targeted interventions have failed. All curative and life-prolonging treatments have been discontinued. She currently is in the hospice care program to keep her comfortable and improve her quality of life. Next. So yes, this would meet the definition. So Mrs. N is currently in hospice care to manage symptoms of her end-stage cancer. Next slide. So understanding the definition of items used as exclusion, how to code them, really matters. So here are trends over time of this indicator and the capture of exclusions. So CI-HI observed the antipsychotic QI rate decline until an increasing trend began in 2020. In addition, exclusions for any reasons have also been increasing linearly over the past decade. Next slide. So here's a closer look at those specific exclusion criteria that coding for this indicator that drove that increase from 10 to 25% over the past decade. So exclusions due to delusions increased 3-folds, hallucinations 2.5-folds, and end-stage disease 6 months or fewer to live was 7-folds. And exclusions related to schizophrenia and Huntington, as well as hospice care, actually remained flat over time. So are these increases true reflections of clinical change in the long-term care setting, or does this really represent variability in how items used as exclusions are being interpreted and applied? Next slide. So following the INTERI standards really matters. So we want to remember to capture antipsychotics taken in the last 7 days. We want to refer to the definition of items in the assessment, in the user manual, and job aids. If in doubt, consult with the physician. Long-acting antipsychotics that are received outside that 7-day observations are also included and to be coded. And remembering that end-stage disease, 6 or fewer months to live, reflects a resident whose condition is deteriorating. And we want to code the presence of delusions or hallucinations only if they are present. Next slide. So we're going to examine how we can use this quality indicator as part of an improvement initiative. Next slide. So these are the basic questions and answers, as well as actions related to a quality improvement initiatives. So what are we trying to accomplish? How do we know that a change is an improvement? And what change can we make that will result in the improvement we seek? Next slide. So in the context of initiating a quality improvement plan related to antipsychotics, here are some suggested steps. We might want to, obviously, we would want to use our facilities data. We would want to review the unadjusted rate of this quality indicator to see what the true reflection, create a plan, determine how to share our progress, and most importantly, we would want to have buy-in. Next slide. So here's an example on how to measure and track progress. So our aim or objective for improvement here is to reduce the rate of the DRG01. The measure is the indicator's unadjusted rate. The current performance right now is 25% in the second quarter of the reporting period. And the target goal we want to achieve is 15%. So the improvement initiative in this example is going to be through medication review, chart audits, and staff education. Then we'll want to track our progress within a realistic timeline to achieve that goal. So in this example, it's achieving that rate of 15% by March 2026. Next slide. So with the intra-LTCF, there are now CI-high long-term care secure reports that facilities submitting in IRIS have access to. One of the reports features all of the quality indicators. Facilities can trend a particular quality indicator and compare at different reporting levels, such as province, regions, and other reporting facilities within IRIS. Next slide. So what we have here is an image of a CI-high long-term care secure report on the potentially inappropriate use of antipsychotic. What we have is a trend visualization, and it's representing Canada over several quarters. So you can create a similar report using your own facilities data and selecting multiple quarters to examine your unadjusted rate to track your progress. Next slide. So to wrap up here, there's a few key messages about antipsychotics. So sometimes used to manage behaviors and symptoms in dementia, but they should only be used as a very, very last resort. If used for indications other than psychosis, careful monitoring is required. Side effects are more difficult to tolerate in older people, and they're also associated to higher risks of falls, diabetes, and heart disease. Next. And about the quality indicator, remember that it's not meant to be punitive, it's meant to improve care. It does not indicate bad medicine. It flags potentially inappropriate use for further investigation. Again, the rate is not expected to be 0%. It's helping us identify residents who could benefit in alternate approaches to manage symptoms. Next. So details about this quality indicator, the calculation and exclusions are summarized in this CI-high job aid. So it is available on our long-term care InterRI resource page. Also, the description of this indicator along with other long-term care indicators can be found in our CI-high indicator library on our public page, and simply by selecting long-term care under types of care. Next slide. And that concludes our presentation. Thank you.
That's wonderful. Thanks so much, Pat, and to Jacqueline. So helpful to have all those examples that really personify the exclusion and inclusion criteria, and also really helpful to hear more about the reporting and the new functionality. So before we turn to questions, and please continue to add any questions you might have to the chat box. I think our advisor and coach, Cynthia, has a few more tips to share on monitoring data. Hi, Cynthia.
Hi. Can everyone hear me all right?
Yeah, you sound great.
Perfect. Well, thank you very much, and thank you very much, Pat, for that wonderful presentation. I just wanted to say you certainly helped to clarify how the indicators are to be used, and I'm really glad that you emphasized that the indicators are not meant to be punitive. It's just a snapshot and an indication of where you might improve your care. So thank you for that wonderful presentation. I'm not going to take up much time. I'm just wanting to talk just a little bit in general about data collection and monitoring. So not necessarily about the CI-high data, but just why you're doing what you're doing when you are engaging in an improvement project. So if we could just thank you very much. Monitoring is important because it does play a vital role in achieving results from a plan. If you're not collecting data, you have no indication of whether you're achieving your goals. And it also helps to determine whether you need to make some adjustments with your improvement project. Are things going off the rails a little bit? Do you need to tighten your focus perhaps a little bit? Do you need to even maybe gather different different data. It ensures that tasks are completed correctly and that any hurdles are overcome in a timely way instead of waiting till the end and thinking, oh no, we should have done something different. It also helps you to allot any budget and make sure it's used appropriately, ensures that your resources, both human and material, are in place, and it provides that very valuable feedback for improvement. Most of all, I think it ensures accountability and it also improves communication, especially if you're sharing your data. Next slide, please. So there are different types of monitoring that typically people will engage in when they're engaging in any kind of improvement project. There are 7 typical types, including process, compliance monitoring, result monitoring, beneficiary monitoring, financial, context, organizational monitoring. But I just want to talk about 2 that I thought might be most helpful to you. And the first is the beneficiary monitoring. And so when you look at your improvement plan, you're asking the question, is the plan meeting the needs of the stakeholders, your staff, your residents, the family? Does it include an element of accountability here? Does it include some educational needs? Does it include empowerment as it relates to the project? The second is results monitoring. And again, this helps to assess the impact of your project because, again, as I've said, if you don't monitor anything, you don't know how well you're doing. So that data collection piece is really important, regardless of how you do it. And you have a wonderful database within CIHI that you are using and reporting every quarter. For those folks that aren't submitting to CIHI, you have other abilities. You have other data that you can look at, including your pharmacy data and other quality indicators that you're collecting in different ways. Next slide, please. Most importantly, it's really important that you share the progress with everyone, certainly with your team. Because it motivates people. They don't feel like they're just doing something because management said we're doing this. They're doing it because they can actually see a difference, not just on the floor with the work that they're doing, but in actual data. So it also informs and it also allows you to celebrate when you look at your CIHI data and you see that, okay, our last reporting period, we were at 25% antipsychotic use, but this reporting period, look at that, we're down to 18%. That's something to really celebrate, right? And on that note, I just want to say that sharing should also include your resident stories, how this impacts the resident, what you're seeing differently, how it improves their quality of life. Because truly, stories are not just motivating, they're the things that people remember the most. Long after your improvement project is over, you won't be talking about the data or the collection or the nuts and bolts of your IP project. It will be the stories that are generated. So please make sure you're sharing that. And I think that's probably the end of my slides. Am I correct? Yes. So I'll hand it over for Q&I. I'm sure there are folks that have lots of questions for Pat and for CIHI.
Wonderful. Thanks so much, Cynthia, for sharing those extra tips around data monitoring and the importance for quality improvement. So yes, lots of questions pouring into the chat box. Thanks for popping back on, Pat, because a few are just kind of to clarify things you did go over about the definition. So could you clarify again if residents not on an antipsychotic are included in the calculation for the indicator, and if so, why? And I wonder if that was perhaps around the denominator where you were showing the assessments.
Okay, so only those receiving antipsychotics over the last 7 days, like at the time of assessment, will be included. So those are the only, that's one of the inclusions. And there are what we call valid assessments. So some assessments we won't even include those assessments. So those who have it's their very first assessments once they're admitted in long-term care, we don't count that one. It has to be the last assessment in the quarter, has to be more than 92 days. Otherwise, we're not going to count that one. So those are some examples of assessments that we don't include.
Mm-hmm. And that's all publicly available on your CIHI website as well. So we could, yeah, look that up if anyone wants to see that. Okay, another question about, can you explain why lithium is included in the CIHI antipsychotic medication list as a mood stabilizer?
So it is a mood stabilizer. It's used as a mood stabilizer, but it is classified as an antipsychotic according to the ATC classification. And that is the criteria for actually including it as an antipsychotic. Although it's used as a mood stabilizer, it is actually classified as an antipsychotic. So it should be counted if that person is receiving it.
Got it. And then similarly, can you speak to bipolar disorder? Why diagnoses such as bipolar aren't included in the exclusions?
Very good question. I might add Jacqueline to this conversation. This is a question we get a lot. And at the current time, it is not included as a diagnosis to exclude. But I will ask Jacqueline to speak a little bit more about it. There is some talk about this particular diagnosis.
Thanks, Pat. So yeah, we've had obviously lots of conversations across the country about this indicator and about the exclusions, the exclusion criteria. And we did have a discussion with INTRI about including bipolar disorder as exclusion criteria, so adding it as one of the diagnoses. And they agreed that bipolar can be considered. However, for our change into our methodology, that right now won't occur until 27, 28. So not this April, but next 27, April 27 is when the change to our indicator methodology will change on our website and in the calculation to include bipolar. Now that might change. Right now, that's what we're doing. We've got lots of changes happening that are already slated for April 1st. Next year, we work well in advance. So that's like starting the work now to make sure that that is included in the files for reporting by that date. So it will be included in the future.
Okay, great. Thanks for letting us know. So this might have to do with that you had showed a trend, the graph over time, Pat, but has CIHI ever seen an increase in exclusions similar to this one before?
Well, it goes back quite a ways. If you recall the graph, I think we have several years, and I think it goes back to probably just before we started publicly reporting on it. So I think we're going back, I think, to 2016. I could be wrong, but
I think I saw 2012. So
2012,
yeah, over a decade.
So
yeah.
I think it's just based on what we have, like at this point, historically. Yes.
Yeah.
And I think we are seeing some variation in the exclusion criteria. It's certainly for other people to look at, like where do you land in the Canadian spectrum of the quality indicator, and where do you land? Are you an outlier, or are you aligned with all the other facilities or comparable facilities? And so kind of looking at that, and we are that could be related to how you're coding the exclusions or how you're coding the assessment. So happy to have a conversation if you see your organization is a bit of an outlier on the exclusion, on the exclusion criteria and what you're coding.
Yeah, great point. Okay, so have you consulted geriatric psychiatrists who presently work in long-term care to help inform your approach with the indicator? Not sure which one
me
of
to
you wants
answer
to take that one.
So yes, we get feedback from all across the country, like I mentioned, from definitely from geriatric psychiatry, but we also work closely with INTRI. So INTRI is the one who owns the methodology for the quality indicator, because this assessment and these indicators are used across the world. So they have a team of internationally known psychiatrists and geriatric psychiatrists who are well versed in this, that they consult on the indicator methodology.
Wonderful. Okay, so this one's a bit lengthy because it's a bit of a scenario. So stay with me.
Okay.
If an assessment is completed and 30 days later, the manager reviews the outcomes before the end of the quarter and sees that a resident is triggering in the section of antipsychotics without a diagnosis, but the manager knows that the resident has hallucinations that are very troubling for the resident. They are on a low dose of antipsychotics and these hallucinations are managed. So the nurse doing the assessment just missed this. Is it important to correct this to ensure that the assessments are accurate, or is this just left as is because it's outside of the assessment period?
I can answer that. We have to, if we follow the inter-I guidelines and the rules, we have to, it's a snapshot in time. So you code what you see, what you hear at the time of assessment.
Mhm.
So, yeah, so you would have to include it if,
Yeah, and then you'll see that change next time, perhaps, if it's corrected with the staff. Yeah. Okay, thanks for clarifying. So another question about exclusions. Will any forms of dementia or behavioral and psychological symptoms of dementia ever be included as exclusions?
I don't see that happening. Jacqueline, if you want to add to that, again, it lies with inter-I whether what they would do. But again, like with dementia, that's the risk, right? So using these medications in this population, it's hard on them. There's a lot of side effects that go along with that. So I don't think they would be including what they call that term BPSD. I don't see that happening.
Yeah. Okay, don't think I've missed any of, I think we've covered all of the questions in the chat box so far. I don't know, Pat or Jacqueline, if you had anything else you wanted to highlight or speak to.
Well, we're
Go ahead, Pat.
yeah. Well, if there's any questions about the whole methodology or the exclusions or the items, please, we are available through eQuery. Like if there's any scenarios or questions that you have, we're always available to support assessors. Just wanted to add that.
Awesome, thanks, Pat.
Exactly. And obviously we're working really closely with the initiative at Health Excellence Canada, but also we're working with Choosing Wisely on the indicator. We work closely with inter-I on the indicator. So we welcome all these questions and kind of taking a different look. If you think about the indicator was developed quite a long time ago, right? And it did have an impact at that time, and then it's still having an impact today. But there are definitely nuances to today's use of some of the medications and for some of the conditions, and also the different populations that we're seeing in long-term care. So we recognize that that's kind of changing over time. So welcome any feedback or questions that you might have about the indicator that we can bring to some of these other tables to discuss. Yeah, and so we'll just continue to look at some of these exclusions and continue to look at the indicator methodology, and even just the name. I think it's about this inappropriate, potentially inappropriate, and so can't stress enough that it's potentially inappropriate. We do recognize in some circumstances that it is appropriate for an individual to have antipsychotics. And so going back to the dementia sort of, it is an exclusion, we're trying to have organizations speak to their physicians and their healthcare team to see, is there an other medication use, or is it appropriate for this person to be on antipsychotics? And that's okay. It doesn't need to be a 0.
Mm-hmm.
Yeah. Wonderful. Thank you both so much. So informative, very helpful, and a good lively chat box. So I'm sure participants appreciated all the clarification as well. And thanks, for your offers of further e-queries and questions as well. Before we wrap up, maybe we'll just pull up the slides again to quickly let you know about our next award opportunity. So Registration for the whole program, Sparking Change in AUA Awards program, is still open, and long-term care homes in Canada can register through the link on the screen, or we'll put it in the chat box as well, and you can navigate to our website. So the program offers support and opportunities to win monetary awards. And if you register before June 27th, which is tomorrow, you'll be entered in our second Kickstarter draw to possibly win one of 30 prizes of $2,000 for your home just from registration. And then you can also submit to the Progress Award, which is worth $5,000 per prize, and that's open until August 22nd. So also for teams who are registered in the Sparking Change in AUA program, we will be hosting an extra Q&A session with Pat and Jacqueline from Kai on July 9th from 12 to 1 p.m. Eastern Time. So you should have already received a calendar invitation and information on this additional session via email. So again, just an additional opportunity for more questions and discussions with our friends from Kai. So a big thank you to everyone for joining us today. A special thanks, of course, to our special guest speakers from Kai and to our webinar producers behind the scenes. So please don't hesitate to contact us at HEC. You can see our email address on the screen. And again, the recording of this session will be available on our website in the coming days. So before you go, we would really appreciate your feedback to let us know if this session was helpful to you. We just ask if you could take a couple minutes to complete the poll that just popped up on the screen. A few basic questions about whether this provided useful information, if you would share what you learned, if you know more about the topic after having participated. And we do collect gender, which is optional, and it's collected on behalf of our funder at Health Canada's request. So thank you again for coming, for providing your feedback. And this concludes today's webinar. Have a great day, everyone.